very much for this introduction. Dear ladies and gentlemen, once again, my name is Miroslav Radenkovic. I'm coming from the Faculty of Medicine, University of Belgrade. I'm a medical doctor and a clinical pharmacologist. So it was very exciting for me that I found that we have a new drug on the market that is going to be used in hypertension. You know that we don't have so many antihypertensives today that are going to be applicable in everyday use. So it is my pleasure to introduce you with aprocitentan and endothelin receptor antagonists. Why endothelin? 20 years, for 20 years, I was a core experimentator and working on isolated blood vessels and investigating endothelial relaxing and contracting factors. And that's why this topic was very interesting for me. At the beginning of this lecture, I would like to thank the organizers for this kind invitation to come here in Rome and to declare no conflict of interest in regard to this lecture. So we know that hypertension is usually treated with drugs like AC inhibitors, angiotensin receptor blockers, calcium channel blockers, diuretics, and sympathicolytics in case of cardiac morbidity. However, in some cases, we know that because of the many risk factors that are adjacent, we can't control hypertension in an appropriate way, and that we have a patient that are having resistant hypertension. So patients having uncontrolled blood pressure despite 3 antihypertensive treatments at optimal dose and from different classes, including diuretics, are those that are recognized to have resistant hypertension. And unfortunately, resistant hypertension is accompanied with significantly increased cardiovascular risks. So we can see that this is really a disease burden connected to the hypertension and increased risk of certain health outcomes compared to those with control essential hypertension is here. So we can see increased the burden of peripheral artery disease, all-cause mortality, coronary heart stroke, and above all, we can see so many people with resistant hypertension having secondary heart failure and end-stage renal disease. On the right panel, we can see some very nice curves that are giving us perspective that those risks, those associated risks are lower when we have combined treatment with several antihypertensive drugs as compared to normal treatment with 1 or 2 drugs. So why endothelin 1? Endothelin 1 is one of the strongest vasoconstrictor substances in our body. Usually, increased concentration of endothelin 1 are connected to some pathological conditions and pathological risks that are here mentioned in slides. However, normal homeostasis of endothelin 1 is preserved especially by normal and healthy endothelial cells producing adequate concentration of endothelial relaxing factors like nitric oxide, prostacyclin, or endothelium hyperpolarizing factor, as here shown in slides. However, under different pathological conditions connected, for example, to diabetes, increased fat burden in the organism, inflammatory reactions, increased concentration of other vasoconstrictors, especially angiotensin 2, we can see the upregulation of the endothelin 1 production, and this is something that we need to be aware of when we are talking about the resistant hypertension. As shown in this slide, endothelin 1 is going to be bound to endothelin A and endothelin B receptors. Endothelin A receptors are primarily concentrated on smooth muscle cells and different other organs, producing particularly some unwanted pathological effects. However, endothelin B receptors are concentrated, are expressed, for example, in endothelial cells, making very nice autoinhibitory loop for when we have a situation of increased endothelin release. So what we can say that endothelin-1 is really connected to some devastating effects in our body, especially in regulation of vascular tone, producing a really strong vasoconstriction. Then it is connected to the proliferation of adjacent smooth muscle cells, promoting the endothelial dysfunction by promoting inside inflammatory and oxidation reactions, cardiac remodeling, and so on. And for like the last one, it is connection with a renal water and sodium absorption regulation. Why? We can see this very nice loop showing us that endothelin system plays an important role in hypertension, especially in volume and salt-dependent forms, which are common features in patients with resistant hypertension, when you can see that besides the classic effects producing an endothelial dysfunction, inflammation and fibrosis, hypertrophy and the proliferation, you can see that increased amounts of salts are connected to the increased aldosterone production and hypervolemia, which is a really, really awful burden to any hypertensive patient. So the scientists were very busy. And in 1988, endothelin-1 was identified, and afterwards, the connected receptors, endothelin ETA and ETB receptors, are also identified 2 years later. And then lots of experimentators started to work of endothelin-1 mechanism of action and how we can find out what this particular molecule is doing to our organ systems. However, what we did in clinical pharmacology, what we found out that many of known blockers of endothelin receptors were indicated for the pulmonary arterial hypertension. However, none of the drugs that were there at the market were efficient didn't show adequate efficacy and safety in the treatment of hypertension. So finally, aprocitentan was positively judged in the phase 3 trial, which I'm going to talk about a little bit later. And in 2024, in I think March or May this year, this drug was firstly registered in the USA for the treatment of resistant hypertension, but you can see with lots of warnings and precautions. If we compare so far known endothelin receptor antagonists in human, bosentan was, of course, legendary molecule, and all the experimentators were dealing with bosentan in their experiments on animals. Then came ambrisentan, macitentan, and finally aprocitentan. What we can see that most of them are indicated in the pulmonary hypertension treatment. However, only aprocitentan was good enough to have a license to be used in resistant hypertension. As for the pharmacological properties, maximal concentration is quite similar among the drugs. However, what you can see that half time of elimination is significantly longer for the aprocitentan, which is very good because we can apply it one time daily. This is very nice. Most of them are metabolized by liver, but also aprocitentan has the part of metabolism through kidney. And as you can see at the right side of this slide, the aprocitentan is non-selective blocker of endothelin A and endothelin B receptors. So targeting a new pathway in the treatment of hypertension by using the blockage of endothelin 1 system is quite nice, because we can see, first of all, by blocking of the receptors, we can reduce the strong vasoconstriction that endothelin is going to produce. Moreover, by this block, we can reduce with some other mechanisms. We don't have a time now for them today. With some other mechanisms, it will reduce the production of other vasoconstrictor substances, especially angiotensin 1. And then we can see that sodium and water retention is going to be reduced, because this very nice action on the aldosterone production. So, unfortunately, we don't see all the, for some reason, I don't know why, we don't see some major clinical trials that preceded the obtaining the license from the FDA for aprocitentan. However, I will show you the most important one, the core study, precision study, which was multicentered, blinded, randomized, parallel grouped, and this was a phase 3 clinical trials. So design was very nice, in my humble opinion. It consisted of 3 parts. In first part, the patients were randomized to obtain 2 different doses of aprocitentan plus placebo. Then in the second part, this was a single-blind study for 32 weeks, where patients were treated only with aprocitentan of 25 milligrams, which is quite high dose. And in part 3, with the withdrawal part of the studies for the 12 weeks, we randomized patients again only to placebo and aprocitentan. And then finally, safety follow-up protocol, we finished with aprocitentan and followed the patient to see how their hypertension is going to be, what the trends are going to be in lowering the blood pressure. I must stress out that all the patients were receiving their therapy, so there was no some ethical concerns that the patients didn't receive their antihypertensive therapy. In this protocol, only aprocitentan was added to the patients. What we can see that the primary and key secondary endpoints were changes in unattended systolic blood pressure measurement from baseline to week 4 and from withdrawal baseline to week 40. And secondary endpoints included 24 hours ambulatory blood pressure changes. From the first part of the study, when patients were receiving 2 different doses of aprocitentan plus and the placebo, we can see that the changes in blood pressure in between 2 doses were not so different. So the efficacy was quite favorable for the lower doses for aprocitentan, which is very important, because you will see later on that the higher dose was producing some serious unwanted effects, where of course both doses were superior in lowering blood pressure comparing to placebo. At the right panel, you can see the third part, when the patients were receiving only placebo and aprocitentan, and the difference is quite obvious. So these are some numbers. I won't read them all together, just to stress out that least square mean change in systolic blood pressure in 4 weeks was minus 15 millimeters for aprocitentan in lower doses, and 15 millimeters of aprocitentan in higher doses, while only 11 millimeters for placebo, and that made very significant difference. And we have some other data from this study. What is important from this slide to see is that aprocitentan in lower doses, while having good efficacy, was safer for patients because a higher dose of aprocitentan was associated with typical unwanted effects from endothelin 1 receptor blockers, and this is edema or fluid retention, anemia, and hepatic disorder. So the lower dose was something that the scientists were needing. And finally, in March this year, Idorsia Pharmaceuticals announced the new drug, and the FDA approved the drug aprocitentan with a generic name for the treatment of hypertension in combination with other antihypertensive drugs to lower blood pressure in adult patients who are not adequately controlled on other drugs. Why this is important? Here are some pharmacological features of this new drug. So aprocitentan produces the inhibition, non-selective inhibition of ETA and ETB receptors. Endothelin 1 via this receptor mediates a variety of very dangerous effects such as vasoconstrictions, fibrosis, cell proliferation, and inflammation. In hypertension, this is also very important because endothelin 1 can cause endothelial dysfunction, vascular hypertrophy and remodeling, sympathetic activation, and increase aldosterone synthesis. So, aprocitentan in combination with other antihypertensive drug was indicated for treatment of hypertension to lower blood pressure in adult patients who are not adequately controlled. However, control of high blood pressure should be part of comprehensive cardiovascular risk management, including, as appropriate, lipid control, diabetes management, antithrombotic therapy, smoking, cessation, exercise, and limited sodium intake. So this is a control of typical, burden factors that are present in hypertension. However, we can initiate treatment in females of reproductive potential only and only after confirming of a negative pregnancy test. I will show you why. And the recommended dosage was the lower one, 12.5 milligrams once daily, because of favorable pharmacokinetics, allowing us to give the drug once daily, with or without food, which is fantastic because our patients don't have to think about time of chosen time when they want to take it. However, there are some warnings and precautions. So Trivio is now still available only through a restricted program under REMS called the Trivio REMS because of the risk of embryo fetal toxicity. REMS stands for the Risk Evaluation and Mitigation Strategy. This is a drug safety program of the FDA, and that can require certain medications with serious safety concern to help ensure the benefits of medication outweigh its risks. So REMS are designed to reinforce medication use behaviors and actions that support the safe use of medications. In other words, prescribers must be certified in Trivio REMS by enrolling and completing training. Pharmacists that dispense Trivio must be certified with the Trivio REMS, and counseling patients who can become pregnant on the action necessary to prevent pregnancy and minimize exposure to fetuses. Very important. And there are some advices for this REMS program, what to do and how to use the drug appropriately when we are talking about the possibility of pregnancy and the manufacturer gave several options for the control of for the birth control, including not only female, but also male partners as well. And that is very good options that both partners would be involved in this process. As for the pharmacokinetics, the absolute oral bioavailability is still unknown. So we are, examining that. But the time to maximum is 4 to 5 hours, and the plasma concentrations increase in a dose proportional manner, and no clinically significant differences in aprocitentan pharmacokinetics were observed following administration of high-fat and high-calorie meal. And although aprocitentan is over 99% bound to plasma proteins, primarily albumin, protein binding is not affected by renal or hepatic impairment. So far, we didn't register also some very important drug interactions that would be connected to this high binding of aprocitentan to plasma albumins. And the half-life is quite long. As for the metabolism, so aprocitentan is primarily metabolized by uridine diphosphate, glucurosinyl transferase family of enzymes that are shown in this slide. And after a single dose of aprocitentan, we can see that 52% is going to be eliminated via urine and 25% via feces. And no clinically significant differences in pharmacokinetics of aprocitentan were observed based on age, sex, race, ethnicity, body weight between patients and healthy subjects, which is quite a good start for this drug. However, we have some serious contraindications. First of all, pregnancy. To prevent pregnancy, patients who can become pregnant should use acceptable contraceptions prior to initiation of treatment, during the treatment, and for 1 month after stopping the therapy. There are some possibility for hypersensitivity. However, warnings and precautions are here. Hepatotoxicity and liver failure, fluid retention, decreases in hemoglobin, and decreases of sperm counts. As we are talking about the liver failure and hepatotoxicity, elevations of aminotransferases and hepatotoxicities are known for all endothelin receptor antagonists. So elevations of ALT and AST are there, and we have to be very careful. Do not initiate aprocitentan in patients with elevated aminotransferases or moderate to severe hepatic impairment. As we are talking about the fluid retention, so also endothelin receptors antagonists are producing fluid retention and peripheral edema. So this unwanted effect was reported in 9% of treated patients, compared with 18% receiving a high dose of 25 milligrams of aprocitentan versus 2% of placebo. Older age and chronic kidney disease are so far risk factors for edema and fluid retention. So we need to monitor for signs and symptoms of fluid retention, weight gain, and worsening heart failure. If clinically significant fluid retention develops, we need to treat it appropriately. If we are talking about hemoglobin decrease, so this decrease is usually presented in early stages on treatment. They are stabilized thereafter and were usually reversible after discontinuation. I have to stress out that this unwanted effect was present with a higher dose of aprocitentan in clinical investigation of 25 milligrams. So initiation of aprocitentan is not recommended in patients with severe anemia, and we need to measure hemoglobin prior to initiation of treatment. And about the decreased sperm counts, the man counseling is should be done before planning the family. So these are the adverse reactions that we were talking about: edema, fluid retention, and anemia. And if we are talking about drug interactions, they are not so many now registered, although we had several clinical studies. For example, I couldn't show it on the slide, with rosuvastatin, for example, and so on. Aprocitentan is a substrate of P-glycoprotein. However, inhibitors of this transporter are not anticipated to influence the pharmacokinetics. You can see the aprocitentan inhibits and stimulates some cytochrome P450 enzymes, and we are waiting for new clinical trials to see how this is going to be transferable to new and possible drug interactions. If we are talking about preclinical investigations, we have two facts: pregnancy and lactation. And based on the animal reproduction studies with other endothelin receptor antagonists, aprocitentan can cause embryo-fetal toxicity. That's why this drug is still prescribed under this specific safety precautions. And if we are talking about the lactations, there are no data on the presence of aprocitentan in human beings. However, if we are talking about preclinical investigation in rats, aprocitentan was excreted into milk during lactation. So when a drug is present in animal milk, it is likely that the drug will be present in human milk. As far as for the specific population, not so many data. So the safety and effectiveness of this drug have not been established in pediatric population. In the geriatric patients, we can see that the edema and fluid retentions was more common. If we are talking about renal and hepatic impairment, I was telling you a little bit earlier about these unwanted effects. However, aprocitentan is not recommended in patients with kidney failure or on dialysis, and not recommended for patients with moderate or severe hepatic impairment, because these patients may be at increased risk for poor outcomes from hepatotoxicity. And overdosage is treated symptomatically. So adverse effects of headache, nasal congestion, nausea, and upper respiratory tract infections were observed. We need to stop the treatment and to call the clinical pharmacologist for other measures. To conclude, aprocitentan is a promising drug. It is orally active, potent dual endothelin 1 receptor antagonist. It has a synergistic effect with other antihypertensive drugs. It demonstrated efficacy in regulation of blood pressure when applied with other antihypertensive drug. So far, there is low potential for drug-drug interactions. We can say that resistant hypertension is often part of multimorbidity, including chronic kidney disease, obesity, diabetes, and ischemic heart disease. And patients with resistant hypertension are therefore at particularly high cardiovascular risk. Aprocitentan is a dual endothelin receptor antagonist acting on both endothelin A and endothelin B receptors involved in mediating vasoconstricting, hypertrophic, pro-inflammatory, and profibrotic effects in hypertension. And endothelin dual receptor antagonism may represent a useful complementary approach to achieve blood pressure control in resistant hypertension patients. So I would like to thank you for your kind attention. For more information, please follow my ResearchGate account, and I'm open to your questions. and thank you very much again.